Hello over there on Facebook. Hello over here on Zoom. And welcome to the March Madness edition of the weekly NeuroCentric Approach Online Academy case study meeting. We do this on a weekly basis right now, where we get together and chat about, sometimes, always, case studies. Sometimes other things that matter too, like the North Carolina State Wolfpack, my home team, whoop, whoop, into the Elite Eight. I was at NC State in 1983 when the Cardiac Pack with Jim Valvano and team won the NCAA championship when I was quite a bit younger, at 1974, when they won their only other NCAA championship. I was an ardent fan then. I had a posters of David Thompson and Monty Tao on my bedroom wall as a kid. And it was not lost on me that in defeating Marquette, that's the same team that they beat in the national championship in 1974. And last night, I thought Houston was going to wind up beating Duke. And if Houston had beaten Duke and State would be playing Houston tomorrow, that would have been a rematch of the NCAA championship with North Carolina State in 1983, when they beat Phi Slamma Jamma with Hakeem Olajuwon and Clyde Drexler. So go Wolfpack. Whoop, whoop. You've been watching the tournament, Mark? What did you say?
I've just been looking at highlights.
Yeah. I've been impressed with the games and overall quality of ball this year. It's been a lot of fun and some really good games. Yeah, it's the only time of year that I move into full-on ACC support. You know, I don't even recognize the ACC or any of the other conferences for that matter these days, like the Pac-2.
Well, the Pac-2 women are in the Elite Eight.
Yep, indeed.
Women.
I know it's fascinating, but yeah, I mean the when I used to really be an ardent follower of this kind of stuff, the days of the ACC when there were 6 or 7 teams and Tobacco Road meant something. There were four primary teams that were always going to show up and hold forth in this kind of tournament. And then usually they would be squaring off in the finals against the Big East teams. The Big East and the ACC are pretty well represented this year. So let's see. As I mentioned, we sometimes talk business and case studies and all that on these. Little commerce, the NeuroCentric Approach Online Academy. 35 hours of continuing education, recorded online continuing education for you folks for your CE needs. And I will give you a little heads up for those of you that are smart shoppers and keeping your eyes open. I am so happy about this March Madness situation, and I'm going to open up the lifetime membership portal again this weekend. Although I probably should wait until after NC State plays tomorrow but I'm going to open it up anyway, just in the spirit of good basketball. And for that, when I open that up, and that's a limited time situation, you can pay one single price one time and get lifetime membership to the online academy. And what that grants you, probably one of the most valuable things, is it'll get you $100 off of each in-person course that we hold. So I will send emails out to all of the people on our email list if you've signed up on the NeuroCentric Approach site for those emails. And I'll also be putting it over here on Facebook and such, so you guys can feel free to take advantage of that. Sometimes we talk about things that have absolutely nothing to do with NeuroCentric Approach. And here's, well, I don't know if it's absolutely nothing. I mean, think about it. In NeuroCentric Approach, we are looking at the effects of sensitized neurology from the biggest compartment, the brain, down to the smallest compartment, and in succession, that would be spinal cord, nerve root, IVF interface, the big mixed peripheral nerves, and then finally the superficial cutaneous neuro. And among the things that will tend to sensitize neurology are those four buckets, the epigenetic buckets that we've discussed in the past. Poorly managed stress, poor sleep, a lifestyle that doesn't include much movement, and possibly includes too much willful self-poisoning, like alcohol and drug use, and tobacco. And in the vein of that, in reducing, just for instance, alcohol consumption, something that I've been keen to try to limit in recent years in my life. We've been exploring, my wife and I in our household, various substitutes, kind of scratch that itch. I like Topo Chico because it gives me a nice mouthfeel, heavy bottle, feels like I'm doing something substantial. But we also started playing with the now very trendy beer substitute things. So there's a brand called Partake out there that's quite good. There is also, that one is a non-alcoholic beer. So it's an actual beer that, contains barley products and things of that sort. And I've been keen too to limit grains a bit in my life. So we trialed another one that's very popular, made by a company called Hoplark, Hoplark. And the Hoplark products we found were quite good. And essentially that is a hop and black tea drink that is carbonated. And I found that to be very tasty. And then, you got decaffeinated black tea, so you got your proanthocyanidins and your epigallocatechins, all that fun stuff. So you got a lot of health promoting things in there. But here's the problem. Those products that don't have any alcohol in them cost the same as those that do. So you go out and for something that is supposed to be mimicking say a Northwest IPA, you're paying 10, 11, even $12 for a 6-pack of essentially tea. And lo and behold, the Hoplark stuff got so popular that you can't even find it now. And when you can buy it, if you buy it online, it's going to cost you twice that. And there's no way in hell I'm paying $20 for a 6-pack of tea. So I got my thinking hat on about all of that. You know what I did? I got on ChatGPT and I appealed to the AI Oracle and I said, make me a recipe for something that approximates that Hoplark tea with and approximates the taste of a Northwest IPA in terms of international bitterness units, and provide some information about mouthfeel and ways to play with that. And damned if it didn't come up with a pretty good recipe. And I went out and tried it, and then I've been testing it. So I'm going to share a little bit of what I did in case you guys are interested in that, because it's dirt cheap. All right, so here you go. You go out to your local brewing store, your home brew supply store, and you ask them where their hops are. They're usually going to be in a refrigerated case. So those of you over here, I chose 2 bittering hops and 1 aromatic hop. I'll talk to you a little bit about how to use that, but I chose Simcoe and Mosaic for bittering hops. And the Simcoe and the Mosaic are the ones that Hoplark uses in their product. So that's, show you guys over here on Facebook. They'll come in little baggies like this, and they're pellets. They look like rabbit food, basically. You take a total of a 1/2 ounce of those pellets. You're going to boil them for about 2 minutes. Okay. You're going to set that aside, pull it off. And when you pull it off from the boil, then you're going to mix in some decaffeinated black tea. You can put caffeinated too if you want, but you don't want to be drinking that at night. Now, I made mine up. This recipe was for a 64-ounce finished product. And I actually cut it in half because that's too big. Our refrigerator's got too much stuff in it. So I cut that in half and made a total end product of 32 ounces using 0.5 ounces, a 1/2 ounce of bitterness hops boiled for 2 minutes. And then after the boil is done, pull that off and pitch or put 8 tea bags of decaffeinated tea in there, and grab a handful of these guys, which are your aromatic hops. And these are just dried whole hop cones. And you grab a small handful of those, toss them in there, and that won't give any extra bitterness. That'll just give you that nice aromatic nose, a citrusy nose. That is a Citra, Citra hop. And I'm going to grow some of those hops over the summer to lower the cost that much more, because hops grow like crazy, y'all. And I will continue to make this. And what I've been doing is that makes up in that 32-ounce concoction that you make up. I can fit that in an Nalgene bottle. Now it fits in my refrigerator. Oh, and in there, a little bit of sweetness. So I use Trader Joe's liquid stevia. And now I've got a keto product, and I can take 2 dropperfuls of this and put in that same batch. Bada boom, bada bing. That gives you a nice little balancing act with that bitterness. And then I take about a 1/4 cup of that concoction and I mix it with Topo Chico. And that gives me a nice head on top. And damn if it doesn't taste pretty good. And it is 100% healthy for you. The hops are great for your sleep and for relaxation. The tea is great for just about everything. And stevia doesn't have any nasty side effects, not going to raise any blood sugar. So it's all peace, love, and guitars, folks. So you heard it here first. I think my per unit cost went from, I think it's a buck, no, what is it? Almost $2 for buying that Hoplark product when it was available, down to, I think I got it down to 30 cents per unit. So smart shoppers. All right. What are we going to talk about this week? I need to put some stevia in my tea. Let's talk a little bit about a couple of previous cases that we've talked about. I got one in process, you guys might recall. Next weekend is a powerlifting event that several of our lifters at Kabuki are attending, including one that I've shared with you. 42-year-old female, master's level current world record holder in her age and weight class. And she was having nasty pain in her right anterior shoulder. And that shoulder pain was interfering with her at the very bottom of her bench press. And the very first thing we did per NeuroCentric approach is I provided some traction while she was performing an upright chest press, which was painful. So that was my index movement. And her pain completely went away with just cervical traction. So we did a bunch of cervical traction, did some cervical manipulation to try to open a putatively encroached upon neural foramen and IVF. And she had some benefit, but it didn't maintain. So then per the NCA processes that we've talked about in the past, I went downstream and sourced the nerves that were involved in the periphery. And the ones that I found that were, the one that I found that was primarily involved was suprascapular nerve. And yet when I did my work on the suprascapular nerve, if anything, it made her a little bit worse. So I went to other nerves that service that particular region, and you guys will review some of these and workshop them in the upcoming in-person course, April 20 and 21 in Portland. That's the upper quarter course. But the other nerves that service that particular area, the lateral pectoral nerve, and the what else is there? And the suprascapular and the axillary nerve. And those service the bursa, the subacromial bursa, the coracoacromial ligaments, and joint capsule there at the AC, and varying portions of the glenohumeral joint. So I went in there and worked on those a bit and got a similar effect. It basically made it a bit worse doing manual therapy, deeper work like TNM, transverse nerve mobilization, over those particular nerves, which is a little more traumatic to a sensitive nerve. DTM would be a symptom modification process, right? You're lifting, creating a little more room around the nerve, and that wouldn't piss it off, but it didn't last on these. And it's difficult to use DTM to get to those slightly deeper structures. You can approximate it over the suprascapular nerve, especially with a cup directly over the suprascapular notch there on the scapular spine. But I had sent her home with some home traction, and after we had trialed McKenzie and we trialed neural dynamics and didn't get any buy-in there. So we were just looking to try to modify things as much as we could with what we had seen beneficial. And in this case, it was making more space at the IVF. And we had some positive findings and then some negative findings. She flared up. We noted that if she got handoffs, meaning someone was delivering the weight on her bench press to her, helping her to get it off of the rack, which is the way it's done in competition, then she had zero pain. So we insisted that all of her training sessions include that. Her target, the world record, is 194 pounds. When she came to see me, where she was in her training, she was upwards of 181 was her PR, I think, at that particular point in time. And we were able to get her with the handoffs and the traction up to 187 for a single in one session, or over the course of 2 or 3 weeks. In one workout session, she was able to get to that number. So we were within striking distance of hitting it. And then she flared up on one day when she didn't have anybody to hold to give her liftoffs. So I got angry at that because then I've got to play cleanup, and then her body has to focus more on healing damaged tissue than it does on building to try to accomplish a physiological task. And we did a calming session on that. And then the following session, she still had some flare up, and I was really not optimistic. But I just leaned into it hard functionally. And I used the regional interdependence model. Remember, mobile upper spine, stable lower spine, mobile thoracic spine, stable lumbar spine, and so forth. And I really worked on her upper back mobility. And as you guys know, I focus on things that the patient can do first. So I had her to do quadruped thoracic rotation, the kneel with the heels, hips on the heels, so that we isolate the material, the movement more in the thoracic spine. And then I had her to do her wall squats. Then I did mobilizations in the thoracic spine. I did overhead squat press from Jersey Gregorick. And that's the primary one for lifters that I like to use, because it's a little more like a regular lift, and they can scale it on their own, and it's impossible to hurt yourself, and they can measure their progress with it. And we'll go over that one as well in the upper quarter course. And then I gave her the Carl Levitt T4 mobilization. And I said, I want you to do that, all of those exercises twice daily, every day before your next bench session, which was 3 days later. She did that. And then I got back word a couple of days ago in her peaking session before the competition, which many of you know will be, she will peak this week, rest this week, this past week, rest this week, and compete next week, next weekend. And lo and behold, she had zero pain in any of her bench, and she was able to work up to a personal record of 191 for a single rep. And according to her coach, she had plenty of gas in the tank So I am very encouraged that she will be able to set a new world record in cumulative total and in the bench. So keep our fingers crossed on that. One other thing that we're playing with her is capsaicin. That will bridge us over to my second follow-up, which will be a bit more brief. You guys might remember the anterior cervical disc fusion patient that I had. That was a top-down process. She had, what was it, 3 months after her procedure, the approach was on the left side, anterior, of course, but she had 7 out of 10 near constant pain in the back of her neck and a distribution that was sort of overlaying the upper trapezius bilateral. And I did some DTM locally on that and it helped a bit, but all we needed to do was just a little bit of extra skin rolling on that area and it flared her up. So to my mind, that's representing hyperalgesia at best or allodynia at worst. And you guys know that that's a function of central sensitization. And what happens to the nerves locally, those local nociceptors in the skin that we're playing with, is that the body will input an extra number of TRPV1 and probably Piezio 1 and 2 receptors on that membrane. I'm going to focus for the remainder of our discussion today on that TRPV1 receptor and talk about why we think it's important more so these days. That TRPV1 is an ion channel for calcium ions. And the Nobel Prize in Physiology and Medicine in 2021 was co-shared by one guy that I've talked about recently on here, Artem Patapoutian, who discovered the Piezio 1 and Piezio 2 receptors, which gave us a window into what actually happens to make a nerve mechanically sensitive, to take it from baseline to being more sensitive to both pressure and tension. And then we've got the more recent, the person that he co-shared the Nobel Prize with was a researcher by the name of David Julius. And Julius gave us is the one who did most of the original research on TRPV1. Now, these TRPV, that stands for transient receptor potential, and the V stands for vanilloid. So TRP is a class of ion channels on nerves. All of them have to do with a variety of different stimuli that change the sensitivity of the nerve to the various things that make nociceptors a bit ping. And you guys remember those are temperature, mechanical stimulus, and chemical stimulus. So when the body winds up that neural synapse that we're talking about there, here we're talking about it in the periphery, you've got that first order neuron that is being sensitized by those TRPV1 receptors placed on the membrane. And then you've got another wind up potential at the second order synapse in the spinal cord in lamina 2 of the dorsal horn. And what happens in there, and then again at the second to third order neuron in the thalamus and hypothalamus. And that's where we have the handoff to the amygdala, the handoff to the hippocampus. So we have things that alarm us for the amygdala, and we want to remember them for the hippocampus. And then we put all of that into some sort of meaning in the cortex. And that's our top-down process. There's our central sensitization, 1, 2, 3. And from a pragmatic standpoint, we could lean into that the way that I'm doing with these two case studies, which is to use, ironically, an agonist, something that stimulates TRPV1. And what is that? It is capsaicin. So capsaicin, you guys know, is the active ingredient in hot peppers. And people, there's a high degree of genetic difference in the ability for people to tolerate it at all places in their body, whether it's eating hot peppers or whether it's excreting hot peppers or whether it's wearing hot peppers on your skin. And there's also a tolerance that builds up to that. So what actually happens on the cell membrane is that TRPV1 receptor or ion channel is occupied by the capsaicin. And if you just occupy it, it can't do its thing and ping such that the other two interneurons upstream will get a signal. Now that's a temporary process with a low concentration of capsaicin. So what I've taken to experimenting with my patients to see, since we've got a high variability there, most entry-level topicals are 0.025%. And most over-the-counter topicals will go up to 0.1%. So we can trial that. It takes about 30 minutes after you put it on for it to, if that's a concentration that their body is sensitive to, then it takes about 30 minutes for it to start working, and it'll stay on there. They'll feel warmth and a burning sensation, which is similar to a reproduction of the burning pain that they feel when they have a neuropathic kind of scenario that's going on. Now, what we've described so far for our lifter is not a true neuropathic pain, but I am bullish enough on the idea that the mechanical and thermal sensitivity of this neurology is that maybe our International Association for the Study of Pain of nociplastic, neuropathic, and nociceptive pain, that just like we recently added the category of nociplastic pain, that we probably are still learning in all of this. And I'm willing to take a chance with something that has very low side effect, and it's only temporary, and there's no long-term negative effects from putting topical capsaicin on. I'm willing to give that a shot. And I suspect, if we liberalize our definition of what neuropathic pain is there, I'm thinking that we include myofascial trigger points as well, because that is probably an interface problem with a cutaneous nerve and in its movement through the tissues. So in my patient with the anterior cervical disc fusion, she went from just doing the manual therapy to doing the manual therapy with the addition of the cream once a day. And she's 75% better, y'all, after a couple of weeks. That's pretty cool. And I would also say that part of the benefit was the top-down portion of having a clear narrative about what she's doing or what she can do to help herself, agency, and having something other than what she had gotten from up to that point the information from her surgeon, which her surgeon threw up his hand. He's like, I can't explain why you have pain back there when we did all of our work up here. And the physical therapist did the same thing. So her two experts she was relying on did not provide any kind of compelling narrative to her. The closest they came, which I was able to lean into and to exploit, was an idea that she was just more sensitive and it might take longer for her to heal. So there's the ACDF. The other one we'll learn more about. I'll give you more about information on next week. I'll throw my hat in the ring on this one too. I've got a I jumped on the bandwagon here to give it a trial. I've got a full-on neuropathy in the back of one heel. It's pressure induced from my walk on the Camino last year. Day one, my feet got really wet. I was wearing minimalist shoes, and my heel just got the daylights beat out of it, and I had the worst blisters I have ever had, and I'm not usually bothered by them. And literally the entire back portion of my heel sloughed off over the course of the 2 weeks on trail, and it was incredibly painful. And I've had hyperalgesia across the whole back of my heel now. This is going on a year at this point, and I've just been kind of being patient with it, but it hurts to go walk a whole bunch or run a whole bunch. And I've got another one of those trips planned in June, so I started using the capsaicin, and lo and behold, it seems to be working on me as well. It will not work on all of your patients, if I'm to believe the literature on this, but I think it is well worth a try. The most significant downside, people put it on and it causes the pain that brought them in to see you. It is an agonist of those TRPV1s. Blessedly, the pain typically doesn't last a long time. It usually lasts about 30 minutes or so. So if they can tough it out, great. If it's a barrier to them using it and being compliant with it, the research on it suggests that you can apply a cold pack when you put it on, and that will minimize the burning feeling, but you'll still get the effect on the TRPV1 receptors. Now, here's the cool part. Prescription capsaicin patches are available. They are 8%, y'all. 8%. So that's what, 80 times more potent than the most potent that I'm aware of that you can get over the counter. And the effect of that is it literally, the axon fibers that preferentially the body has increased the concentration of TRPV1 on them. And mind you, that TRPV1 receptor is not upregulated on most axons. But when that nociceptor pings a lot, that's when it gets input on there. Now, at this point, in my understanding, I don't know what the half-life is on those on those TRPV1 channels. One would assume that over time they would wash out, and your body would, would recalibrate to something that's a bit more normal. But what we have learned from the research on this is if you put a high concentration of capsaicin on there, it opens all of those TRPV1 receptors, which means calcium ions flow in, and that basically for that axon is neurotoxic, but highly selective. So it prunes selectively that portion of the neuron that has those TRPV1s on it. The rest of the neuron is fine. The nerve is fine. The cell body in the nerve is fine. So it will regenerate that portion. And what the emerging evidence right now is suggesting is that the portion that grows back in will have fewer, if any, of those TRPV1s on it. So that's a home run. Again, doesn't work for everybody because of genetic differences and possibly epigenetic differences. But the places that they have expanded on that is because it's only very local, you can't get it deep to nerves that are affected that are deeper, like sensory, articular sensory branches. So they're working with injections to get the capsaicin deeper. And there are human trials right now ongoing that the preliminary responses are very encouraging of injecting it intra-articularly as well. So we'll keep our fingers crossed and see what we learn. What you got, Brian?
So if they do that high percentage capsaicin, is it just a one-time application?
Yeah, the papers on it suggest that the benefit takes about 30 minutes to take effect. So put it on for 30 minutes, typically with an ice pack, and you wear the patch for 30 minutes, and you take the patch off. And in most people, it lasts for 12 weeks.
Wow.
Not bad. Yeah,
So
and
just
cheap.
like your hops brew, could you do your own home brew of capsaicin patch?
You're getting to know me a little bit here, mate. I am thinking about putting together something, trying to see if I can figure out using the Scoville unit metrics for hot peppers. If I can
Yep.
find an equivalency between Scoville units and the percentage of capsaicin, and then try to put together something and just make my own, uh, 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 call it a massage oil or something of that, and maybe make it out of Scotch bonnets or something similar, habaneros, some of Mark's son's scorpion peppers, or you know Carolina Reapers would be an appropriate one given the some of what we entered in with today. But yeah, I think I could do that with some coconut oil and make something yummy there.
another over-the-counter tool that drives things deeper into the tissues would be DMSO.
Yeah,
I don't know if there's anything in the research or if you've played with that, but it would
I
be a
played
way to
with
get.
I played with it with other items to do exactly that. And then, even in some cases like Chris Duffin has played with some of that with various things to try to stimulate healing for injured tendons and muscles, and then use phonophoresis or I guess the broader extracorporeal shockwave therapy as well, just exploring different ways to try to drive things into tissues with sound. But yeah, that's I think DMSO would be another issue, but you can't grow DMSO on a vine, Mark, and it's a little harder to get over the counter too. So, yeah, I think but we'll keep an eye out for the topical coconut oil Scotch bonnet pepper concoction. Mark will work with your son, who's making the culinary products, and then we'll make a product and rub it on your shoulder, put it on your food. And yeah, I think that could go quite nice. Mix it in with curry, and then take a bath in your curry.
So Philip, is capsaicin the only thing that affects that TRPV1, or, how does the other analgesics like my area, a lot of people like that deep blue, it's an essential oil. Is that just a distraction to your sensory nerves basically, or what's the?
It's an excellent question. Remember I said the TRPV1 is part of a family that we're learning more about of these TRPV receptors. And there are other TRPV receptors that work on slightly different stimuli. One of those stimuli is menthol. So that's the counter irritant effect that we've known, you and I and all the rest of us for years of, athletes back in the day using Kramer-Gesic. I remember one of the nasty tricks that everybody would play, and one person every year in football would, some guy gets Kramer-Gesic or ice, that kind of icy hot put on his jock strap, and midway through practice you see him go running off the field. But the yeah, guys are interesting. But that's one class of receptors on that. There are other things other than capsaicin that stimulate the TRPV1 as well. They have isolated a pharmaceutical that will will turn that receptor on and won't turn it off, and so it's irreversible. So that holds some promise as well for that selective pruning of those affected axons. But in all likelihood, what we have seen from, call it folk science or bro science or whatever else, and all these various liniments that people have made and done, made oils and things of that sort for use in body work and all. Those are probably working on some of those other various channels. I'm just looking at three of the three papers that I was reading this morning on all of this. Let's see if I can get to the part regarding
So
that.
would you mind posting those on the NCA site? That'd be great.
Sure, I can drop those papers in the community forum there when I post the link for the recording later on today. Yeah.
Are you telling patients then, like the one with your anterior fusion, that it's going to be a long process of that pruning, like a 3-month process? Or
Well, actually, no, the pruning process only takes potentially, depending on the concentration, somewhere between 30 minutes and 2 weeks, depending on
that's
the
not bad.
concentration. Yeah. So what I'm doing to minimize discomfort and to try to maximize compliance is I get them to start off with the lowest concentration, and you can pick that up for like 10, $12 on Amazon, right? The 0.025%. And then when they notice that it doesn't burn anymore, then graduate to the next one. And then if it's a really severe case, I mean, this has been used for post-herpetic neuralgia. The 8% has been used for post-herpetic neuralgia and diabetic neuropathy successfully. And again, 12 weeks of benefit there. So I think I recall you and I had some conversations about ideas about managing some of those neuropathic pain patients. And here's a place to consider to lean in on. But you're probably going to need to get a physician in your community to get a prescription to that 8% to have the real long lasting benefit, I would imagine.
Yeah, and with the neuropathy, that's got to be a pretty big patch, or maybe you just do it on the heels where they're having the problem. Or
exactly right.
Well, Philip,
the effect's very local. The effect's very local, and so it's wherever they're having their symptoms. Those are the axons that are expressing those TRPV1 channels.
I was
No,
gonna,
I'm just
go ahead,
I
Mark.
I missed some of the earlier discussions on top down, and I thought for top down you were going to go into some psychology component of it, and I'm tickled to hear uh, this particular approach to top down that I'm not familiar with and is more purely physiological, not to negate the psychological component, but to have something that would change that top-down pain that quickly is fabulous. So
Yeah,
thank you.
Mark, sure. Was Rich Gillette at Western States when you were there?
I never went to Western States. I was at Western States. I was in Portland for a few months after I graduated, getting ready to take the board in
Okay.
late 79, early 80. So
Alex
yeah,
is on here. I know Rich was there when Alex was there. But I still remember sitting in Rich Gillette's class and getting the emerging science at that point, 20, 21, 22 years ago on wind up at each one of those first order, second order, third order neural synapses, and also on the nerve itself at that point. Alex says that was exciting at the time, and yeah, it really was. And Rich was so into it. I mean, he was a legitimate neurophysiologist who was doing bench research on that kind of material. But yeah, he's the one that introduced me to D.O. Hebb and Hebbian assemblies. And D.O. Hebb, some of you know, he was at McGill University, and his grad student was Ron Melzak, who we are aware of for coming up with the neuromatrix of pain description. So that was a very heady time of figuring out these different inputs. And Mark, I think it was 2 or 3 weeks back, our Saturday conversation, I talked more that time too about
Dale's there. I'm gonna head.
I talked. Hang on a second. I'm gonna mute you there. I think I talked more at that particular point in time about that first order, second order, third order place in clinical process and how to intervene at each one of those points. But yeah, there's a full-on physiological event that's going on there. And then, cortically, we get to the brain-based stuff, and that's us trying to make sense of the physiological event that's going on in the body downstream. All right.
That all sounds really cool right now. I was just going to say, I have an interesting patient that we had as a presentation we have this regional presentation that goes on for docs that don't know what to do with a patient that we do on Thursdays. And this one patient that was presented is a young guy that had his first flu immunization in the end of October, and within a day or two developed pain, and then started to have what looked like, especially lateral antebrachial cutaneous nerve distribution of pain. So they were thinking, and what the group consensus was, is we're either looking at Parsonage-Turner syndrome, or we're looking at there's a vaccine injury site one also. It could be that one, but it really sounds like capsaicin might be a beaut for him, especially if we do the workup where we do increasing concentrations so that he can tolerate it and start to get those nerves to quiet down. It's terrible pain. So sounds like it'd be really helpful.
I think one of the things you mentioned there too, Alex, it's worth keeping in mind is either right where there are some good reports in the literature of case studies demonstrating injection injury to the radial nerve
Yeah.
from, shooting a little bit too low there. And sometimes it appears that the injury to the nerve is a result of the local inflammatory response.
Yeah.
And sometimes it appears that it is direct physical trauma where they actually skewer a good portion of the nerve, and then downstream.
Unfortunately, the administration of the immunization was not by a doctor. It was by the cook
Ah.
on the ship. And so I suspect you're right on that. So we're going to be looking for a couple of things on that one too.
Yeah, we saw a lot more of that too in the COVID pandemic because, people were being recruited to just get jabs in arms, and there people were very, they were just getting an in service of just an hour or two, and we're sticking needles in arms. My wife is a psychologist, and she was trained that way at Kaiser to go and deliver injections.
Yeah, one of the things we're considering is some hydrodissection also for this guy. So they'll be looking at a couple different places. But the interesting thing is that he is showing that LAC component of the pain. So they're probably going to request an EMG just to make sure, because he still has weakness. There's some persistent weakness as well.
Well, if you still got persistent weakness, then yeah, that does look like radial nerve injury rather than they probably skewered it. And that if that's the case, that's going to be a harder one to fix if it is if a neuroma has formed. But that said, I did find some papers that suggested that the capsaicin patches are helpful in phantom limb pain as well.
Brilliant.
Which, with those neurites and the neuromas that form after that, they're the source of that excitable signaling that's going on locally that the body's confused about. And those are TRPV1 axons.
Yeah, I appreciate it. I mean, this is really good input for us. He's one of the lucky ones. He's local at Bremerton, so he's going to be coming to our program eventually, but he won't start with our program for a while. But his PA in our program has already seen him, and I can give her some intel on this and how to maybe help him out with it.
Yeah, sounds good. I look forward to a report on that at some point in the future.
You got it.
All right. We're about ready to quit here, but Brian says he's got a quick question about shoulders and NCA versus meat-based ortho tests. So go with question, Brian.
I'll keep it short because I know we all have lives. So I had a patient this week, weightlifter for many years, and basically, testing just muscle tests for all the rotator cuff muscles, and everything was strong, but he couldn't abduct above 90 degrees very well or reach behind. And I thought, well, with where his pain was at, I just did a little cupping over the supraspinatus nerve. And within a minute, he had full abduction.
Nerve?
Or suprascapular nerve, yes. And he had full abduction with that. So my question is, when you're doing your exam, if you do see full strength on most of your tests for all your rotator cuffs, you pretty much probably rule out any tendon pathology, correct? Or do you still? So what I learned from that is I'm like, well, let's just go in and check all the nerves, and lo and behold, they're quite sensitive, and that notch there in the scapula, and just doing a little bit of DTM and TNM, he was amazed with how quickly he saw results. And we ruled out cervical spine. We checked all that out. So
we cover all of that flow in the in-person course. The but to give it to you based on how it's delivered, first, generally with most shoulders, you've got you can get an index movement relatively quickly. And for most of those patients with shoulder pain, it's usually going to be elevation of some sort, either flexion or abduction. And the first thing that I'll do, like I was mentioning with the power lifter that I was talking about earlier, they do their index movement, and I say, all right, go up to pain. And let's say they get up to, 120, 140 degrees. It's like, okay, there's my pain. And I'll get behind them on the bench and I'll just provide traction and hold it there for a second and say, and quite honestly, commonly, if that is the issue, then almost immediately you'll see them go higher. And then there'll be this kind of interesting pause where they'll go, huh. And then they'll put their arm down and they'll work it through several times while you continue to provide some traction. And then I take my hands away and they move their arm, and often it's remarkably better. Now, that would suggest at least part of it is here. And I always encourage to capture what percentage of change there was in their pain. And I don't get excited until around about 30%. And if they say, 30%, then I kind of make a note of that. We want to apply inputs to the spine, both at home and in clinic. And then go downstream and work downstream and see if we can get any additional percentage improvement. And then we just stack those cumulative improvements. Now, in that patient, I don't assume anything about the tendon or the joint until I've ruled out all of my nerves. Okay. Now, once I've gone in and ruled those nerves out, and you've seen the shoulder video online, the online course, there's 4 primary nerves that most commonly show up there. And they all come off at C6 nerve root, C7 nerve root. And we can usually lean into that and get a good bit of that shoulder pain taken care of. But here's the spicy part about dealing with shoulders. And with any of these, if you've got a pissed off nerve, our model shows that local muscles will tighten to try to preserve the health of that nerve. So they will try to offload movements to reduce the impact on the nerve. And that alters joint kinematics, and that can cause joint problems. And in the shoulder, that usually can start to cause enough change in the arthrokinematics that they will shrug. The shrugging narrows the subacromial space and pitches the shoulder forward. And in that position, they will more likely have either a closing phenomenology on the joint, on the rotator cuff when they do overhead work, or with the forward pitch, create more tension on it. So depending on, which side of the argument you want to get on with subacromial pain syndrome versus subacromial impingement syndrome that's rife in the literature out there these days, for both of those, elevation and forward movement, it changes the impact on the tendon somehow. And that can make the tendon an issue. So then you got a combo platter that you got to deal with. Yes, you got to get rid of the cause by getting the neuro calmed down and get it out of the way as much as possible. But you're probably going to need to go in and do some joint mobilization, do a little bit of McKenzie, extensions and internal rotations to try to stretch the capsule a wee bit, and do your loading parameters like I was talking about with you on email, or excuse me, on the community earlier today for the isometric loading and such. Cool.
No, good flow chart. No, thank you.
Yeah. Okie doke. That's it for the weekend, guys. Go Wolfpack. Let's see. You guys had a North Dakota boy on what was the team the other night? God, he was a kid that dismantled Carolina when they played the other night. He was a North
Well,
Dakota.
NDSU kid. Yeah, I can't
Yeah,
think of his name. But there's
yeah,
a
he was awesome. That kid's got a bright
Oh,
future. What's
and
that?
you, Oregon State, fight, fight, fight.
Yeah. Yes,
Beaver women
indeed.
looking good.
Yep, no doubt.
Elite Eight. Took
All
out Notre
right.
Dame. I'm happy with that.
Yep, no doubt. All right, so I'm gonna go see if I can get me a 20 miler in at some point this weekend, Alex, and we'll see how the leg holds up.
I hope that heel feels good.
Yeah, my
What
dog.
shoes are you wearing these days?
I'm in Hoka Speed Goat 5s.
Oh, nice.
Yeah, they suit me well, especially walking, because of the rocker heel.
Yep, I
Uh,
love that rocker bottom, man. It's
they
nice.
they
Patients love
manage
it too.
yeah, they manage that impact a lot better on walking than
Yeah.
the other items that I've used before.
I haven't graduated out of the Hoka Bondies yet, but I started trying there's a new one, that I just got. Super soft, really feels nice for the older structure of the heel and the tissues
Mhm.
associated with it.
Mhm.
It is, yeah, I'll send you a picture.
Yeah, yeah, it's fascinating to see the shall we say maturation of that
Yeah,
whole process. I've been a minimalist shoe advocate for most of my career,
yeah,
and then arthritic changes from old turf toes,
yeah.
and yeah, I had one toe with turf toe when I was a teenager, and I've got some pretty significant arthritis and hallux limitus in that, and then the other toe was in Hawaii a few years ago, and um, wound up. I think we were over on Kauai, and I was trying to get out of the surf zone
Oh,
swimming, and in a swell, I went over a rocky area. And when I kicked, I hit a sea urchin on the rocks,
oh no.
and it went right into the capsule of my other MTP. And it's funny, I used some BPC 157 on that, trying to work it out. And, it wasn't an intracapsular injection, it was just sub-Q. But that stimulated something on what I assume must have been an inclusion cyst on that, because the
Oof.
whole area turned the same blue that it was with the sea urchin ink.
Holy
It,
smokes.
it was fascinating. But,
Those
that
were they were
helped.
Saucony Triumph 20s.
Yeah.
And
Okay.
everyone has them on sale right now. They're like really nice heel cut.
Cool.
And has a lot of forming to foot capability.
Awesome.
Yeah.
Okay. Well, let's get out there and enjoy a beautiful weekend. Happy Easter. And
Happy Easter.
I will see you guys next week.
Roger that.
Copy.